this is Dr. Susan Sarajari from Dominion Fertility. Thanks so much for joining me here today. I'm going to talk a little bit about PCOS, particular about what it is and how we treat it to create a family for you. So PCOS is really a very common endocrine disorder which affects about 4 to 6% of females in their reproductive age. It's been around for a long time. It's been first discovered in 1935 by these doctors called Stein and Leventhal. PCOS is usually a syndrome that presents with irregular menstrual cycles, also known as oligomenorrhea, or amenorrhea, which is no menstrual cycles. A lot of times patients have also excessive hair growth, particularly on the face, the chin, the upper lip, and so forth. And sometimes you can have a finding of elevated male hormones in those patients. And lastly, some of the patients can also have polycystic ovaries. Now, polycystic ovaries are really ovaries that have a lot of egg-producing cells in them, more so than normal. So usually when an ovary has 12 or more egg-producing cells in it, then it's called a polycystic ovary. Now, to make the diagnosis, you do not have to have all those things here on the screen, but you have to have at least 2 symptoms in order to call it PCOS. For example, irregular menstrual cycle and excessive hair growth, or excessive hair growth and polycystic ovaries, and so forth. Now, where does PCOS come from and what is it caused by? And the cause of PCOS is still a little bit elusive, so we're not quite sure. There is no specific genetic contribution that has been elucidated, but we know that it runs in families. So sometimes the sister or a mom of a patient also has PCOS if the patient has PCOS. In terms of environmental factors, there are also no specific environmental factors that have been implicated. However, one thing we know is that patients who have PCOS are a lot of times insulin resistant. And that means the body's cells don't respond normally to insulin, so the body has to produce more insulin in order to control the glucose. 80% of the time, obesity is also seen in patients with PCOS, and our PCOS patients a lot of times have a lot of trouble losing weight. So that is very common. Now, in terms of the hormones that are abnormal or increased with PCOS, you can see a particular increase in the LH hormone concentration, which is your luteinizing hormone. And this abnormal LH secretion can also cause an increase in the male hormones, which are your androgens. And then that excessive insulin that you have around that we just talked about, that can independently also increase your production of androgens. So you have this male hormone production through 2 mechanisms. And all these hormonal abnormalities then lead to you having irregular menstrual cycles and not ovulating right. The medical consequences of PCOS, you definitely want to make a diagnosis, not just for fertility, but also for health reasons. Because patients who do have PCOS, in particular if they're also are obese, are at a 3 to 7-fold increased risk of developing type 2 diabetes, as well as increased risk of developing cardiovascular disease, because PCOS is a lot of times associated with elevated cholesterol. And then in addition to that, if patients don't have menstrual cycles, they can be at risk for endometrial cancer or uterine bleeding, and obviously infertility. Now, when you go to your doctor, he or she will do a hormone evaluation, and this is what we usually do. So what you want to take a look at is the male hormones, which is your total and free testosterone and your DHEAS. And then you want to rule out any other causes of the PCOS, because, for example, if you have elevated prolactin or thyroid disease, you can have irregular cycles. And so you want to make sure you get a thyroid and a prolactin hormone. And you also want to check your ovarian function by getting the FSH, the LH, and the AMH. In addition to that, I will usually get glucose testing, because like I just said, patients with PCOS have increased risk for diabetes, as well as a fasting lipid panel. And then we also look at the ovaries with the ultrasound and see if those ovaries are indeed polycystic or not. So this is usually the workup for PCOS.
And can that be done in our office?
Yes, they can definitely be done all in our office, all in one go.
Great.
Now, in patients who are obese, the first line of treatment is a lot of times diet, exercise, and weight loss. Now, usually a little bit of weight loss, just like 5 or 10% of your body weight, can already improve the situation. And by losing weight, basically your insulin resistance is decreased, it reduces your excess male hormones, and it can improve ovulation. And obviously it decreases your risk for diabetes and elevated cholesterol and so forth. So that would be the first step. And then we also start patients on metformin, which is a medication traditionally used in diabetes treatment, but it also has advantages in terms of PCOS. By lowering your fasting insulin levels, it also decreases your male hormones, and that way improves your ovulation rates. So it's a really good medication to be on. However, with the metformin, you have to be on it for at least 3 months in order to see an effect. Now, once the patient has been on metformin for 3 months, we can certainly start with treatment if they don't conceive naturally. And traditionally, Clomid has been used as the first-line drug for PCOS treatment. However, we don't use that much anymore because it also has some negative effects by decreasing the quality and quantity of the cervical mucus, as well as keeping the endometrium sometimes very thin, and that is not supportive of a pregnancy. So the drug of choice now for PCOS treatment is letrozole, also known as Femara, and it doesn't have those side effects that I just mentioned with Clomid. Letrozole is given the same way as Clomid. It is a pill, and it comes in different dosages. We usually start at the 5 milligram dose, and you can start on cycle day 3, 4, or 5. You take it for 5 days. And then once you're done with taking the letrozole, you come back and we do ultrasound monitoring to see if you're making a follicle. Once we have a follicle, we give you an HCG trigger injection and then either tell you when to have intercourse, or we can pair it with an intrauterine insemination, an IUI. So this is kind of your first line treatment. Now, not everybody responds to letrozole, particularly if they have a higher BMI, it might not work. And so then we have to look at other treatment options. Another treatment option would be giving gonadotropins, which is injectable medication with an insemination. However, this is not really recommended, and we really don't do it because the injectable medication is very potent, and sometimes people make a lot of egg-producing cells and a lot of follicles, and the cycle might get canceled. And with something like that, you're also at higher risk for ovarian hyperstimulation. So you want to definitely avoid that. So this is really not done very often anymore as treatment. So for patients who fail the letrozole cycle, they usually move on to IVF. And for IVF, they're really good candidates because they do have a lot of egg-producing cells. So usually we get a good amount of eggs from those patients. And the patients have a really high success rate of conceiving. In order to keep them safe and not have them hyperstimulate, nowadays, instead of triggering ovulation with HCG, we trigger with a medication called Lupron, and that helps avoid ovarian hyperstimulation. And then we usually do a single embryo transfer of an embryo that is chromosomally normal, so we test them with PGT, and then success rates are really high. So this is kind of PCOS in a nutshell, and thank you so much for joining me here today. I'm Dr. Susan Sarajari from Dominion Fertility.